I'll cover these clinical endpoints for metronomic studies, metronomic clinical trials. So, what is the endpoint? It's a selection of the metronomic endpoint has a considerably influence on the reliability and interpretability of clinical trials, intending to evaluate the benefit to risk profile of an intervention. So, basically, studies to study, trial to trial, people keep on change or considers different kind of endpoints, like sometimes progression-free survival, sometimes disease-free survival, sometimes stable disease, complete response, and ultimately overall survival. There is not anything called ultimately, but we can consider overall survival as ultimate goal, because as far as cancer trials are concerned, everybody should look upon these survival benefits. So now whatever I am going to talk or whatever we are going to explore is basically with reference to this overall survival, because if we consider overall survival is a base, and with respect to overall survival base, how we can proceed or how we can make new endpoints as representative of overall survival, that is goal in metronomic study. So now what should be the condition to be endpoint is that the most important characteristic in guiding the selection of primary metronomic endpoint is definitive trial is that effects on such an endpoint should provide reliable evidence about whether the intervention provides clinically meaningful benefit or not. And obviously, as far as OS is concerned, is one of the endpoints. But always we can't consider OS. The primary outcome measures in definitive trial should be a clinical event relevant to the patients or the endpoint that measure directly show how a patient feels, functions or survives. Where the functions refers to the patient's ability to perform actively in the daily lives. Such outcome measure can be called as clinically meaningful endpoints or clinically efficacy measures. Now see, here I am using this term measure directly how a patient feels, functions or survives. As far as survives are concerned, the survival status and overall survival, it's a time dependent variable. It's a time dependent variable where the duration is considered as well as time status of the patient considered. So it's a twisting of durations as well as status. The both things are considered in survival. But in case of others, clinically endpoints, how a patient feels or functions, these are time independent. Till now, people are considering patients feels or functions eligible to time independent as a time independent. But so that is a twist. So how we will consider the survival status as a time dependent or endpoints as a time dependent or not time dependent? So that need to be taken care. And if we consider that or want to establish new endpoints and want to prove that is as equal or as effective as like OS, to proving that we have to consider that endpoint that is time dependent. If it not time dependent, then we have to make some assumption, some algorithm into the statistical methodology considerations that can be considered as equally as a variable representative of OS. Now why these surrogate endpoints comes into the picture in metronomic endpoints? A surrogate endpoint is the outcome measure used as a substitute for clinically meaningful endpoint. Changes induced by a therapy. It is expected to reflect change in clinically meaningful endpoint through the surrogate endpoints. Now see, everybody wants to get some quick results, and obviously because in case of metronomic or any trial, any data, we always like to get some quick results, and for OS we have to wait long time. That's why it's required to consider the surrogate marker, and the definition of surrogate marker says that it should be equally reflect the change of the clinically meaningful endpoints as like OS. Many outcome measures used in clinical research are not clinically meaningful endpoints, but they are indirect measures that are used as a surrogate endpoint. So there is another way of thinking that if it not equally or as effective or as a clinically endpoint, indirect effect can also be considered. Now choice or job is to work the validating a surrogate endpoints through the consideration or in light of these primary endpoint or clinically endpoints. That's a challenge. That's the work. Now why? Because as far as phase 1 studies in metronomics trial are concerned, it's having no toxicity. Even if toxicity is there, Dr. Pravesh Gupta yes, mentioned today morning that yes, toxicity is there, but even if you can consider that no toxicity is there in grade 3 or grade 4, so in terms of that we may consider toxicity is not there in case of metronomic study. So in that case, no maximum tolerable dose is there and no choice with dose limiting toxicity. So we have to keep in mind this, there's biostatistics group, Peter Thal from Department of Biostatistics, MD Anderson Center. Since 1991 they are working on this aspect, maximum tolerable dose and dose limiting toxicity. Basically it's a trade-off between the toxicity and efficacy. So ultimately we have to land up in a ultimate dose or optimum dose where we will be having minimum toxicity and maximum efficacy. That's the way all the traditional chemotherapy drugs are standard or approved through the initial trials, initial stage. But in case of metronomic chemotherapy, since we are using very low dose, very severe or toxicity is not a problem in case of metronomic study. So in case we don't have one wing, only we are having one wing, that is only efficacy. So we have to take a decisions based on this efficacy of a dose that can give this ultimately clinical benefits. So how we can make whatever this today till procedures or statistical methods are available, that is 3+3 dose escalation methods, or like Simmons methods, but all of them are basically stand between this trade-off between this toxicity and efficacy relations. But here we have to extend our work, we have to remove the toxicity part, only efficacy part need to be considered. Reason to consider surrogate are again endpoints again. The experimental and follow-up prolongs the study. The experimental therapy is correlated with an increase in response rate. The chance of responder lives longer than the non-responder. That's the main problem in case of overall survival itself also. So there are so many assumptions behind overall survival. One of the assumptions that we many times overlook is that we assume that responder and non-responder both will be having equal survival duration, but it's ultimately we may consider, we don't consider it, but it should be considered, and based on that the statistical methodology is concerned, stand on this assumption that responder and non-responder will be having equal survival duration. I'm talking about the assumption. In reality it may differ. Now the most important point is that the experimental therapy on survival duration should be engaged by its effect on an objective response. As a result, survival duration among non-responder and responder required to be equivalent. That's always not happen, and there should not be any observed residual treatment. So what happened, generally we conduct our study for 2 years, 3 years, 5 years, whatever the duration is there, and after that closing that date we assume that those are not died or even not occurred, they are censored. But after completion of study they are all having some kind of duration of life. Maybe they are responder or not responders. That's the limitations in case of overall survivals or clinical endpoints to be considered. So that is called this residual treatment life, residual life of the patients. So that's one of the limitations. So to avoid these surrogate markers can be considered in metronomic trial. Now how to? Step 1 or level 1 is a true clinical efficacy measure. Level 2 is a validated surrogate marker. Level 3, it's a non-validated surrogate marker, yet one established to be reasonably likely to predict the clinical benefit. And level 4 is a correlated, that a measure of biological activity, but that has not been established to be at higher level. So level 1 is so easy, like Any example like progression-free survival. Progression-free survival can be considered as surrogate marker in case of level 1 because it's already a proven surrogate. But the new surrogate marker you want to establish, for that you have to validate the process, you have to make a assumptions and make a as effective this marker as like already established clinical marker, clinical efficacy marker like OS. So that's a one step ahead job, tough job. Third level is that consider a non-validated surrogate marker and try to find out it's as effective or as predictive, better it's words, as predictive as well as overall survival is. And the fourth level is to correlate this complex biological activity to establish a higher level. So that is more complex challenge. So in metronomic chemotherapy, since we are talking about the anti-angiogenesis and there are multiple targets, so level 4 is ultimately going to handle, we have to going to handle, we don't have other choice. At all endpoints like level 2, 3 and 4 are indirect outcome measures. Measure at level 1 and 2 likely to be appropriate primary endpoint in definitive or registrative clinical trial. Level 3 measures might be considered as primary endpoints as far as FDA guideline is concerned, subpart E and subpart H, and level 5 measures may be strongly correlated in natural history with direct measure of the patient's clinical status. Now come to why surrogate in metronomic endpoints. Tumor endothelium is a target for anti-cancer treatment. Proliferating endothelium cell from the tumor, even if qualitatively different from those of blood vessels in the normal tissue of origin, remain potentially normal and genetically stable cell. Given the substantial risks that effect on surrogate can provide misleading information about the true effect of intervention on clinical efficacy measures. It is important to consider nature of scientific evidence that would allow one to use surrogate in place of clinically meaningful endpoints in definitive clinical trial. The concept of metronomic scheduling requires the development of appropriate intermediate surrogate markers which can be monitored before and after therapy and repeatedly manner. Like if you want to measure performance of a surrogate marker and want to measure through the scan, so it is ultimately choice is that keep on doing scan. It's true that it's not possible always to do the repeated manner scanning and PET scanning like this, but ultimately if you want to establish a marker, surrogate marker, so initially or establishment should be done with before and after therapy and repeated manner itself. Any quantitative or qualitative changes in profilations of endothelial cells also need to be monitored, closely need to be monitored, which changes how the numerical value of the surrogate marker changes throughout the treatments or observations. The concept of high-term chemotherapy defined as the longest possible period of drug exposure at the given desired drug concentration. So as far as what extent you will see this performance of surrogate markers through close monitoring is the high time of chemotherapy exposure is defined. So now this pharmacokinetic and pharmacodynamics drug involvement also required to be carefully assessed during this to establish a surrogate marker or marker as a surrogate. The rationale underlying dose density chemotherapy is completely different, being based on the concept of administration's multiple cycles of cytotoxic doses of chemotherapy, often involving weekly or fortnightly schedule with short interval to reach highest possible dose. The aim is to prevent regrowth or resetting tumor cells between administration, thereby minimizing the possibility of acquired chemoresistance. Now, example with PFS as a surrogate marker in metronomic endpoints. How PFS can be established at individual level surrogacy. The PFS can be considered as surrogate endpoint for OS if the PFS become highly correlated with OS at the patient level measurement. As a choice, the Pearson's correlations on duration of progression-free survival and overall survival should close to 1 to consider PFS as surrogate marker for any study. So now, problem is that PFS, and there is a little bit people to consider PFS as alternative of OS, definitely, but OS is there, OS where we consider the death as an event, and death is a permanent event. And what time the event occurred we can notice easily, but in case of progression-free survival, event, definitely it's a permanent event, but what time the progression occurred, it's very difficult to find out. So quantifying the duration of progress started, that's a tremendous job, and that is a very difficult unless and until you do these so closely monitors of these markers. And that's the problem to consider the PFS as an alternative of OS to be considered. However, numerically, if you in your study, if these progression-free survival durations and overall survival durations comes close, because both are continuous variable, if come close through Pearson's correlations, then we may consider progression-free survival as an alternative of OS. Now there is another way to consider, that is Spearman correlation as an alternative of Pearson, because there is a limitation in overall survival also. That is limitations with censoring that I already mentioned. The censoring can be ignored, then Spearman correlations can be adopted to explore the relation between OS and PFS, and PFS can be established as a surrogate endpoint of OS. So here I am giving PFS as an example to consider as surrogate marker, but in metronomic chemotherapy we are having other biomarker, even gene markers. Then and the problem is that the gene markers are not time dependent, and establish these gene markers as a representative of OS, it's a complex statistical methodology problem. However, in context of metronomic chemotherapy, the situation is bit different. Numerous studies are now conducted to evaluate the initial advantage of molecular target agents given either alone or in combination with another regimen. Situation becomes more complicated when you are having combined drug, combined therapy, and multiple target agents. It is not always expected that such agents are likely to improve tumor response rate. It is often predictable that such agent will provide better OS or PFS or any of these. Now coming to this angiogenesis part, angiogenesis is required to sustain the growth of both the primary tumor and development of metastasis. Therapeutic targeting of tumor angiogenesis was initiating to consider at a time when molecular mechanism underlying the abnormal neovascularism were known. Problem is that the cellular and molecular basis of biological process is complex, and it's very difficult to identify and emphasize only one target and consider this as a surrogate endpoints. It allowed the identification of several molecular target and different selective approach for inhibiting angiogenesis. In that scenario, defining the single target agent is very difficult. Now in that aspect, since I'm collaborating with Dr. Bijay Patel, and in that aspect since last 2 years we are working on that, and initially we targeted that to find out this optimum biological dose in any marker and through the predictive risk modeling, and in that case we make some kind of predictive risk modeling through simulation data, and also I consider this prior informations through this Bayesian approach. So that's one work we had. It's under process to determining the optimum biological dose of metronomic chemotherapy. And now recently another work we had done to make this time as a bridge and threshold value of a marker, that threshold value of a marker detected through the ROC curve, and time has make a bridge, and we had done this linked with this overall survival. So basically we had adopted a approach that time dependent ROC curves, very new approach we had adopted. So time dependent area under the ROC curve for detecting the optimum biological dose has been now we had done, and we hope we are done with this simulation data techniques, and I hope it will give us the statistical methodology support to establish a metronomic surrogate marker through the time dependent bridge and take as a representative of overall survivals. Thanks.